Morning, everyone. One way to get a medical oncologist to your rounds is to invite him to speak. 7 a.m. start is is tough for us internists. So I'm going to just go through managing prostate cancer and really focus in on the systemic treatment of the disease, and go through first defining the population, current management strategies, and then go into mechanisms of prostate cancer progression, and then end with some sort of just discussion on some of the upcoming clinical trials and other prognostic modalities like circulating tumor cells. So first off, just defining the population. I was a fellow 10 years ago, and that's when I first met Martin. And at the time, there was very little that we were doing on the medical oncology side of things for prostate cancer. And really, in terms of defining the population, it was just progressive disease after castration. And in general, these were older patients with a lot of comorbidities, and their bone marrow was compromised from metastases and radiation, for example, for palliation. So by the time we saw these patients, there was actually very little to do, and the only treatment at the time was Mitoxantrone chemotherapy, a very well-tolerated chemotherapy, not a lot of acute side effects. Rate of severe side effects is less than 5%, but also doesn't do a whole lot. It doesn't change median survival. In this trial from CALGB, randomizing patients between mitoxantrone and steroids versus corticosteroids alone, there was no difference in overall survival, although the median time to progression was slightly prolonged from 2.3 to 3.7 months. So, and it does also have some palliative effects. So that was the state of the art 10 years ago. And so where have we gone now? So in terms of defining the population, because of the earlier use of hormone therapy in patients with just a biochemical disease recurrence, we're seeing a much different population now, I think, than we were 10 years ago. So hormone-refractory prostate cancer or castration-resistant prostate cancer is really defined as just a serial rise in PSA with a castrate level of testosterone. And obviously this is a very heterogeneous group from patients with just a rising PSA. They get started on hormones, and then eventually their PSA starts to rise again. And these patients can have a very prolonged survival, and really not the 1 year median survival we're talking about, but 24 to 36 months or perhaps even more. And then we're doing more scans and identifying metastases at an earlier time point. So even patients with metastases, their median survival may exceed 2 years. And then finally, even in the symptomatic cases, we're probably identifying these patients earlier and recognizing that it's not osteoarthritis, but actually metastatic pain that's causing the back pain. And therefore, these patients are also doing well, and their median survival is now in the 12 to 18 month range. So in terms of what to do next in terms of systemic therapy, so we've established that the PSA is rising, testosterone is at castrate levels from LHRH agonist or orchiectomy. Oftentimes the second line therapy to do, or the next therapy to do, would be second line hormone therapy. And here the premise is on the fact that the adrenal gland produces about 10% of androgens, and therefore you need a greater suppression of androgens, circulating androgens, to induce effects. But in fact, in terms of second-line hormone therapies, a lot is done. We all do it. We all do it multiple times. But in terms of evidence for its benefit, there's very little. In fact, there's only 2 randomized controlled trials looking at second-line hormone therapy in this condition. First, that was reported actually in 2001, EORTC, randomized patients that were symptomatic between flutamide versus prednisone. And the idea here would be that flutamide would be a better inhibitor of hormones, as it was more specific, as compared to prednisone as a non-specific inhibitor of adrenal gland synthesis. 201 patients were randomized, and essentially the effects were the same: PSA response rate of around 20% and a palliative response rate around 40 to 50%, although the palliative response rate was judged by the physician and not the patient. The other randomized controlled trial was conducted by the CLGB, and really was just kind of a proof of principle trial. And it randomized patients between antiandrogen withdrawal alone, so stopping flutamide, bicalutamide, or nilutamide, versus antiandrogen withdrawal plus ketoconazole, high doses, and hydrocortisone. Here the idea is that high doses of ketoconazole causes adrenal gland suppression of all steroid synthesis and steroid hormone synthesis, and thus you have to replace hydrocortisone. Here, the PSA response rate with anti-androgen withdrawal alone was only 10 or 11%, and this was lower than what had been reported in case series before. With anti-androgen withdrawal and ketoconazole, the response rate was about 30%, and there was no difference in the crossover. This was a mostly asymptomatic group of patients. And so when you think of a 30% response rate, and in the symptomatic patients it was about a 20-odd% response rate, one has to think, well, maybe it's just the hydrocortisone alone or the steroids alone. And really, ketoconazole plus hydrocortisone has never been compared directly to steroids alone. And high doses of ketoconazole can be toxic. 30%. So in terms of second-line hormone therapies, we got a lot of options. There's a lot of case series and phase 2 reports of various maneuvers. You can initiate maximum androgen blockade if patients are just on orchiectomy therapy, higher dose bicalutamide, corticosteroids, anti-androgen withdrawal if they're already on anti-androgens, ketoconazole, switching anti-androgens, and even estrogens. And there was a recent presentation or poster at the last GU-ASCO looking at estrogens in a phase 2 trial. And all of them, you'll see a response rate of 20 to 30%. But really, what are we doing on survival or outcomes? Not really been well defined. And are we actually changing natural history? But I think these are all well tolerated for the most part, and relatively cheap. All of them, everything is off patent, and therefore you see some very good biochemical and symptomatic responses, and therefore still a worthwhile maneuver in some patients. So what else do we have currently? Well, the other treatment to come along was zoledronic acid. This is a bisphosphonate, the most potent bisphosphonate currently, and essentially works by poisoning osteoclasts and inhibiting their function. And there was this trial which looked at zoledronic acid versus placebo in patients with metastatic hormone-refractory prostate cancer to bone. There had been several other bisphosphonate trials before with clodronate, pamidronate, and so on, and these were all negative. So in this trial, it was a 3-arm trial, placebo versus zoledronate, 4 milligrams, versus zoledronate at 8 milligrams, although because of kidney toxicity, that was later amended to patients to receive only 4 milligrams. And the primary endpoint was skeletal-related event, and this was basically taken from the breast cancer literature and stamped onto this trial for prostate cancer, but very reasonable endpoints: pathologic fracture, spinal cord compression, radiation to bone, surgery to bone, change of anti-neoplastic therapy for bone, and hypercalcemia. Obviously, in prostate cancer, we don't see hypercalcemia, but this was taken from, as I said, the breast cancer literature. So in terms of the primary endpoint, it was a positive trial for patients in the Zometa 4 milligram arm. They had 11% absolute reduction in the skeletal-related events in the 15-month study period. Now, it was a bit odd is that the 8 milligram arm, which had been reduced to 4 milligrams because of that renal toxicity, there was not a statistical significant difference, even though the exposure to zoledronic acid was the same. So that could just be a power issue. And this is what it looks like, skeletal-related events over time, and obvious a difference between the 4 milligram arm and the other 2 arms. It was a well-tolerated, zoledronic acid is well-tolerated, and really no significant difference between toxic effects between placebo and the 4 and 8 milligram arms once it had been decreased for renal toxicity. So definitely a positive trial in terms of that endpoint. But when one looks at other aspects of patient benefit, they did look at pain scores, and this is the pain graph from the trial, and it showed differences between the placebo group and the zoledronic acid arms. But I think one has to be cautious with that. If you look at this scale, it's between 0 and 1, and the pain scale was out of 10. So the differences in the pain scores are less than 1 out on a pain scale of 10. So I would argue that is not a clinically significant difference. Analgesic use and quality of life scores were not different, and survival was not statistically different. There also can be late toxicities, one of them being osteonecrosis of the jaw. And this is just a graph of incidence of osteonecrosis of jaw over time. This is with a first or second generation bisphosphonate in terms of incidence of osteonecrosis, and this is with zoledronic acid. So within that time frame of that trial, which is an exposure of less than 12 months, there's actually very few. But if we're thinking about bringing this to earlier disease, we need to be cautious, because after about a year's use, the incidence of osteonecrosis of the jaw becomes exponential. In terms of cost effectiveness, the number needed to treat is 1 in 9, so that's about $60,000 for one event. And that one event may be radiation to a rib, for example. And so the cost effectiveness needs to be balanced on the treatment that you're giving once every 3 weeks by IV. So I think it is a positive trial, but you have to look at these caveats as to whether you use it or not. And I think I think where things are going is going to be earlier disease and then more targeted therapy, and I'll get into that in just a second. So one of the aspects of earlier disease that's interesting may be that we could get greater benefit by bringing it there to either prevent metastases or prevent progression. And this was just presented just a few weeks ago, and really it's an update of a MRC trial, 2 trials, PRO4 and PRO5. And these trials randomized either patients without metastases in the PRO4 or with metastases in PRO5 to receive standard of care with or without clodronate versus placebo. And what they did is this was an update. Now, there's a little bit of problem with this update. So they were looking at overall survival in not the full cohort. And they were using a registry to look at survival rather than actually going to actual primary patient data. So it was a bit odd why they did this. Why didn't they just do a real overall survival assay or assessment? And they only looked at patients that were living in England and Wales rather than all over. So I'm not sure what's wrong with Scotland or so. So it's a little bit odd. But in the end, they generate some hypotheses, one of them being that in the patients with M1 disease, there was an actual overall survival benefit. So these are hormone-sensitive patients, and an 8% absolute improvement in 8-year overall survival. Although in the M0 patients without metastases, there was no survival benefit. So flawed analysis, but still intriguing, and will be looked at in 2 trials that are ongoing. There's the CLGB 9202. So these are patients with metastatic disease, castration sensitive, and it's hormone therapy plus zoledronic acid versus placebo. And the primary endpoint is time to first skeletal related event. The other trial is Stampede. This is being put on by the MRC. This is a massive trial, 5 arms, and will probably accrue 3,000 to 4,000 patients. And it's taking patients with high risk localized disease or metastatic disease, and they're randomizing to hormones plus or minus docetaxel, zoledronic acid, celecoxib, or various combinations. And the primary endpoint will be failure-free survival, and if those arms that don't make it there will get cut off, and then the arms that are left they'll look at for overall survival. So we may actually answer the question whether bisphosphonates in earlier disease actually will help survival and time to first skeletal-related event. I think the other one that will be coming along and will be reported this year, and so will be very interesting, is denosumab. Denosumab is a monoclonal antibody to rank ligand, the denosumab itself is very easy to administer. It's given as a subcutaneous injection. Patients can do it themselves at home. And in the metastatic setting, they're looking at once monthly injections. So basically, it's an inhibitor of rank ligand. So the rank ligand pathway has been shown to be very important in osteoclast function and survival. And this is just a schematic showing how this all works out. So rank ligand is produced by prostate cancer cells, but also, of course, produced by osteoblasts. And what happens is that that binds to the rank, which is a receptor activator, and NF-kappa B, which is on osteoclasts. And that basically activates them and allows them to survive. Osteoblasts also produce osteoprotegerin, which is kind of like a sink for rank ligand, so keeping the whole thing in balance. So denosumab is specific for the rank ligand, so by taking out the rank ligand, you don't get activation of osteoclasts. So it already has proven efficacy in osteoporosis, physiologic osteoporosis, but also treatment-induced osteoporosis. There was a large trial done in breast cancer and patients with breast cancer, and also a large trial done in patients with prostate cancer, comparing directly to zoledronic acid. And if I'm not mistaken, it's going to be presented at the EAU at the end of this month. So they're already gearing up to get this going. So I'm going to assume it's a positive trial. So what else is there? So moving on. So the third treatment that we have is basically chemotherapy. And multiple trials of chemotherapy have been performed in the past and have essentially been negative. until this one. And this was a trial that randomized patients between receiving the old chemotherapy, Mitoxantrone, which was good for quality of life, but not much else, to either two regimens of Docetaxel, 75 milligrams per meter squared every 3 weeks, and Docetaxel weekly. And the primary endpoint was overall survival. These are the results. This is data that's now 4 or 5 years old, and basically Docetaxel every 3 weeks won, and the Docetaxel weekly did not. The hazard ratio was 0.76, so a 24% reduction in the risk of death if you receive Docetaxel every 3 weeks, with a median survival of about 18.9 months. So even Mitoxantrone, again, these are patients, about half of them were asymptomatic. The median overall survival was 16 months, compared to previously it had been 12 months. So again, the stage shift that occurs over time is an important one to consider. Response rates, pain response was about 35%, for Mitoxantrone was about 20%, PSA response 45, 50%, and there was a quality of life response as well. So patients, this is the number of patients that had actually an improvement in their quality of life. So there is toxicity with chemotherapy, but patients, because of relief of symptoms, would actually improve their quality of life. And this is pretty good considering that about half the patients did not have symptoms, so you couldn't really improve their quality of life any better than that. Objective response rates were low though. Treatment was reasonably well tolerated. Every 3-week Docetaxel causes neutropenia in virtually all patients, but doesn't really translate into significant side effects. The risk of neutropenic infection, febrile neutropenia, is less than 5%. And grade 3-4 toxicity, severe or life-threatening toxicity, was less than 5%. So in this elderly population, it's reasonably tolerable. So the first take-home message, there are limited treatment options for hormone-refractory prostate cancer. In terms of second-line hormonal therapies, there are benefits on PSA. Are there any other benefits? Don't know. But certainly it's a good maneuver for patients with mild or no symptoms, chemo-ineligible, and it's inexpensive. For zoledronic acid, the pros are there's a benefit on the number of skeletal-related events. The cons are there's probably no other benefits. There's long-term toxicity, cost-benefit ratio, and really questionable treatment duration. In terms of Docetaxel, it has benefits on overall survival and quality of life, but the cons are that there can be acute toxicity and it can be severe. And only when we did a survey of looking at all the patients with prostate cancer or that died of prostate cancer over the last 5 years, only about 20 or 30% of them had actually received Docetaxel. Now, obviously, whether this is appropriate or not, I don't know. There's probably an age selection, for example, but there also probably is an access issue and physician issues in this. So clearly we need better. So what are some of the next things? One is going to be prognostic and predictive factors, and the other one is going to be novel therapies. And I'll spend the last half of the talk talking about those two issues. So in terms of prognostic factors, many have been identified: performance status, visceral metastases, the absolute PSA value, rising PSA, presence or not of pain, Gleason score, etc., etc., etc. And various nomograms have been built, and the current one that's most popular is the Halabi nomogram, published in JCO 2003. And this is right now being prospectively validated in some randomized controlled trials, so may take over things. But one of the issues is that this was developed on patients from the 90s, and then being validated 10 years later. And there's been certainly a stage shift, and as well, during this time, there's been additional prognostic factors identified that are not built into this nomogram. One of them is the rising PSA and the rate of rise in PSA. And this is an example from patients with non-metastatic hormone-refractory prostate cancer in a trial and patients were on placebo. So if their PSA doubling time was less than 6 months, they had death or more likely progression with bone metastases, in median in about a year's time. But if their PSA doubling time was longer than that, their median time to develop bone metastases was 3 years, and if it was even longer than that, they didn't reach a median. So PSA doubling time is important in hormone-refractory disease. This is another one for patients starting on chemotherapy. If their PSA doubling time was less than 6 weeks or 44 days, then their median survival was only 14 months. But if it was greater than 44 days, then they had basically almost a doubling of their median survival, 26 months. The other thing that's going to come along and is being validated right now is circulating tumor cells. And basically what we can do is identify and enumerate numbers of cells that are circulating in the peripheral blood. And this is the only FDA-approved system to do this. And it's been approved for several cancers: colorectal cancer, prostate cancer, breast cancer. And in Vancouver, we are the only ones with a machine or with the equipment in Canada. Essentially, 7.5 mils of blood are taken, and then and essentially these cells are identified based on EpCAM positive and CK positive, basically epithelial cell markers. And this is as opposed to leukocytes, which would be CK negative, EpCAM negative, but CD45 positive. It's a semi-automated system. We just take tubes of blood, and then it's processed, and at the end the cells are identified and then can be counted and as well characterized. Each of these tubes is about $50, and this is not a cheap test. If you were to get it in the States, it costs about $600 to $1,000 to get done. So it looks important in prostate cancer, or it could be potentially important in prostate cancer, because we really have a hard time assessing targets and response. So in patients, our really only quantifiable measure of whether a patient's having a benefit is looking at the PSA. And we know that, for example, in patients that are receiving docetaxel, patients that ultimately will go on to respond, 30% of them meet criteria for PSA progression before they have a response. So and certainly they're not a surrogate for overall survival and other survival outcomes. And as well, we don't really have an ability in the hormone-refractory disease, because most of the disease is within bones, obviously, to be able to biopsy these and know what the current targets are for novel therapeutics. So getting these circulating tumor cells may help us in a couple of areas. One is to look at response. If these circulating tumor cells decline, then maybe that is an indicator that the treatment's working. And as well, if we can characterize them, maybe we can identify molecular targets for novel therapies. So this is just an example of how we can look at this. This is from a trial of docetaxel plus a novel agent, ABT-751. And here's a nice example where PSA is in red. This is baseline, and after each of the cycles, the PSA comes down nicely. And so looking at the circulating tumor cells, even though just after the first cycle, these things basically plummet down to less than 5 in this particular patient, even though the PSA had not declined by very much at the time. But ultimately, it did not really help us because the PSA was going down anyhow, and so it doesn't really help us. But here's an example where it can help us. This is a patient with a rapidly rising PSA. This is his baseline, and after cycle 1, his PSA actually goes up. And so you may say, and never actually goes down, just basically stabilizes. And so, this patient would be classified as a non-responder. But clinically, he improved significantly, and his circulating tumor cells went down quite low and eventually went down to less than 5. So again, may be able to identify the patients that are responding more accurately. And a prospective study has been done looking at circulating tumor cell enumeration. So patients prior to chemotherapy had circulating tumor cells done at baseline and then while they were on treatment. And basically the magic number is 5. So if you have less than 5 circulating tumor cells, then you do better, basically having a doubling of your overall survival compared to patients with less than 5 circulating tumor cells, or greater than 5 circulating tumor cells at baseline. It's probably not just indicating tumor burden, because patients with significant tumor burdens may actually have not very detectable or undetectable circulating tumor cells, but it may be indicating behavior, whether there's more shedding of these cells, more vascularity, and so on. It may be indicating that kind of behavior, not just tumor burden. Plus, if you get therapy, you monitor the circulating tumor cells. If you have bad numbers, so greater than 5, but go to less than 5 circulating tumor cells on treatment, then again your prognosis changes, and you do as well as if you had less than 5 and stayed at less than 5 to begin with. Contrary, if you have less than 5 but go to the greater than 5 on treatment, you have a worse survival than the other groups. These can also, as I said, be characterized. This is from David Huntsman's lab. where we look at circulating tumor cells looking for the TMPRSS2 ERG fusion gene, which is pathognomonic for prostate cancer and occurs in about 50% of prostate cancers. And we could identify the TMPRSS2 ERG fusion within these circulating tumor cells, indicating that it's not just an epithelial cell, but also a prostate cancer cell. And we can use it to identify other things. This is from a patient on a trial with an HSP27 inhibitor. So we can find the circulating tumor cell, but also see whether it's expressing HSP27 as a potential predictive factor in this trial. So take-home message 2, we have prognostic factors for hormone-refractory disease. Ones that I use are performance status, PSA doubling time, presence of visceral metastases, high hemoglobin or low hemoglobin and high LDH. Circulating tumor cells is still, and although it's an FDA-approved test, how to use it is evolving, and it's in a very expensive one. And whether it adds to what we're doing right now is being looked at prospectively in randomized trials. But if you do have a patient that has these negative prognostic factors, we certainly consider earlier intervention with chemotherapy, even if they're asymptomatic. So I'm going to end with talking about a couple of clinical or a couple of agents, and obviously there's a lot that's going on against a number of targets, and I'm not going to go. Obviously, I can't go through all of these, but I'm going to focus on two. One is abiraterone, which is targeting androgen receptor activation, and the other one is a local invention, OGX-011, developed in Martin Glee's lab. So when you look at targeted therapies in cancers in general, where we've had the most efficacy is in when we've been able to identify and target molecular mechanisms that underlie that cancer's progression. A good example of that is, of course, the BCR-ABL tyrosine kinase in CML. And if you target that, there's lots of responses. Same with GI stromal tumors in c-KIT. If you target that kinase, you get very good efficacy. And then another, of course, is the sunitinib in renal cell cancer because of the von Hippel-Lindau mutation driving angiogenesis. So when we think about prostate cancer, the obvious question is, well, so what's driving prostate cancer? And several lines of evidence suggest that in castration or in progression after castration, the androgen receptor is still driving things. And I'll just review some of that data. This is it's not like breast cancer where you have ER positive, ER negative, and then patients that are no longer responding to hormones often become ER negative when you rebiopsy their samples. In prostate cancer, it may actually be the reverse. So here's an example where patients with benign prostatic hypertrophy, samples were taken from them, and then untreated primary prostate cancers, so hormone naive, and then samples from patients with hormone-refractory disease. And in fact, instead of the AR being less important, it appears to be more important. It's amplified and overexpressed. And another key article from Charles Sawyer's lab looked at a mechanism of hormone-refractory progression based on androgen receptor overexpression. So taking the LINCAP model and overexpressing androgen receptor, so in the intact mice, there was no difference between those LINCAP cells that had AR overexpressed versus those that were wild type. But in the castrate mice, those that were wild type did not progress quickly, while those that had AR amplified did. So basically, androgen receptor was required for hormone-refractory progression. And then if you knocked out androgen receptor, again, in these cells, there was no progression, but in the cells where you did not knock out androgen receptor, there was progression. And this increased androgen receptor may actually turn antagonists to agonists. So if you look at bicalutamide, the genes that it was turning on were similar to the genes that get turned on by an androgen receptor activator. So essentially, androgen receptor was essential for hormone-resistant progression. And this is from Paul Rennie's lab, where they took well-established cancers that were hormone-refractory, knocked out androgen receptor using shRNA, and basically saw similar things where you could actually induce regressions in tumors that were so-called hormone refractory. So basically a hormone maneuver targeting androgen receptor induces an effect in a hormone-refractory tumor. And then when one looks at whether so we know that androgen receptor is important, and again, here's another example that androgen receptor is overexpressed in recurrent hormone-refractory prostate cancer, but in addition, there may be actual hormones or androgens within the tissues themselves. And these androgens may be actually produced not just by the tissues, but the prostate cancers themselves. So not just an endocrine effect from, for example, an adrenal gland production of androgens, but also a paracrine effect from tissues producing androgens, but also a autocrine effect where the prostate cancers themselves produce androgens in the context of an amplified androgen receptor. So to bring this on a clinical example, this is a patient that I recently saw. So in 2001 gets diagnosed with Gleason 9 adenocarcinoma of prostate, PSA is 1100, and he's treated with intermittent androgen suppression. 2004, rising PSA, and so he gets put on maximum androgen blockade, flutamide followed by bicalutamide, and then further progression, and he gets corticosteroids, mitoxantrone, docetaxel, and G-CSF. And then he gets referred to me for second-line experimental treatment. And the first thing I always do is check testosterone. And in fact, his testosterone was almost normal at 13. And at one point or another, somebody forgot to give him his LHRH agonist. He had extensive lymphadenopathy, 10 centimeter supraclavicular mass. I restarted his hormone therapy, and within a month, he had a reduction in his mass size. Testosterone undetectable, PSA went to less than 0.03, and he said he'd never felt better in 3 years. Obviously, he'd been getting steroids and chemotherapy in that whole time. So just to emphasize, so the patient that's so-called hormone refractory is really just castrate resistant. And in fact, they may be hormone hypersensitive because of this upregulation of the AR amplification. So how to target this? I titled this Old is New because really it goes back to ketoconazole. Ketoconazole is a potent inhibitor of, or not a potent, is not a very potent inhibitor of adrenal gland production of steroid hormones. And so one of the ideas is to build a better mousetrap, and that's abiraterone. It was actually developed by the Cancer Research UK. And essentially it blocks CYP17, and this is a cytochrome P450 enzyme with dual action. It blocks both 17-alpha hydroxylase as well as 17-20 lyase. And that basically shuts down steroid hormone production. As a result, you get increased corticosteroid and aldosterone because you're shifting this whole cholesterol steroid synthesis pathway this way. And really the only side effects from this drug have been because of increased aldosterone, so hypertension and low potassium. And this can be corrected by just giving regular doses of prednisone, 10 to 20 milligrams a day, and that suppresses this effect here. These are some phase 2 trials in patients. Most of them who had received prior docetaxel, and you're seeing durable greater than 50% PSA declines in about 50%. This is a waterfall plot showing maximum change in PSA. So even these patients where we had previously had no therapies, we're seeing regressions. And again, this is repeated in 2 other studies. Here again showing anti-tumor responses and PSA response rates in about the 50% range in these patients that are chemo refractory or progressing after chemotherapy. And again, here's another example. Here are patients that had no prior ketoconazole. Here are some patients with prior ketoconazole. So the response rate seems to be a little bit less, not surprising, given the similar mechanism of action of these 2 drugs. And right now there's a phase 3 trial that's just about closed, actually, randomizing patients between placebo and prednisone versus abiraterone acetate and prednisone. And I think we put about 25 patients on this trial over the last 6 months, and you cannot tell who's on placebo and who's on abiraterone. And certainly we've seen some very good effects, and they tend to occur very quickly. Within a few days, you know who's responding or not. But either it works or it doesn't. And whether it works enough patients to actually improve overall survival for the population remains to be seen. So we'll probably won't know those results till about 2010. So take-home message 3, hormone-resistant cancer is not really hormone-resistant, just castrating-resistant, and patients may be hormone hypersensitive. So definitely continue LHRH agonist therapy till the end. And really, we're back to the future. New therapies will target the AR and AR axis. Abiraterone looking at production, but there are now new generations of anti-androgens better than bicalutamide, nilutamide, and flutamide. For example, MDV-3100, which will be entering phase 3 trials this year. So the last trial agent I'm going to talk about is Clusterin, and this was basically characterized, and the drug inhibiting Clusterin was developed in Martin Gleav's lab. Clusterin is transcriptionally regulated by heat shock factor 1. It's a heterodimeric glycoprotein, and it's highly conserved across species. There's two forms of it, secretory clusterin and nuclear clusterin. Secretory clusterin is really the one that's relevant for cancer. It's a cytoprotective chaperone protein with anti-apoptotic function, and with one of its main mechanisms to inhibit apoptosis by inhibiting activated BAX. In cancer, it's overexpressed in a number of cancers, including kidney, bladder, ovary, lung, colorectal, breast. And in prostate cancer, increased expression correlates with higher Gleason score, and there's an increased expression after neoadjuvant hormone therapy in the surviving cells. And overexpression in preclinical models confers broad-spectrum resistance, and then knocking clusterin out increases sensitivity. So to target it, we're using OGX-011. This is an antisense oligonucleotide. It's complementary to the secretory clusterin mRNA and therefore knocks it out. But what it also does is by knocking out the secretory, you actually get through splice variation increase in the nuclear clusterin, and that's the pro-apoptotic version of it. So you get a double whammy, both knocking out the anti-apoptotic form of clusterin, but also increasing up the nuclear clusterin, the pro-apoptotic form. And in animal models, the OGX-011 is effective in improving hormone therapy and chemotherapy. So in our first trial, we did a neoadjuvant design. Patients received hormone therapy plus the OGX-011 initially as a loading dose, followed by weekly treatments. And then they had surgery within 1 week of their last dose of the old 11. The idea here was to look at side effects. We already knew that this kind of compound, the antisense, are well tolerated. So more importantly, we're trying to look at biologic effects, whether we were actually hitting target and getting it into the tissues. And really, for the first time for antisense, we did show this. We showed that it got into tissues. A lot of people didn't believe antisense would work. And in fact, our first grant for this that we applied for, the reviewer, the first statement was, "It's generally accepted antisense therapy does not work." That was the first sentence from a grant review. So we had to prove them wrong, and certainly we saw tissue concentrations that increased to levels that were associated with biologic effects in preclinical models. And then we saw target effects. We saw messenger RNA get knocked down to less than 10% or less than 5% compared to historical and controls. And as well, we inhibited clusterin protein and saw increase in apoptotic index. So basically in historical controls and at lower doses, the apoptotic index was about 10%, which is what we'd expect, but it almost doubled with higher doses of the OGX-011. Clusterin can also be detected in serum, and through a number of trials, we saw that at the higher doses, we could knock down serum clusterin. So again, showing that it's having biologic effect, and we combined it with chemotherapy in the form of docetaxel. And when we went to test in prostate cancer patients, we did a randomized design. Because of the stage migration and differences in patient population for response rates, we wanted an internal control to see whether the OGX was really adding to the docetaxel chemotherapy. So 80 patients, metastatic hormone-refractory disease, randomized to receive either the OGX with the docetaxel standard chemotherapy versus docetaxel alone. And certainly we've seen some good things. In terms of time to off treatment and progression-free survival, it was in favor of the patients that received the OGX-011. They received more cycles, indicating that it was perhaps more effective, but as well tolerable. So patients weren't coming off for toxicity. And in addition, we were seeing less primary progressors. So the chemotherapy works, as I mentioned before, in about 50% of people. 20% of people get about stable disease, and about 30% of people have progression as best response with chemotherapy alone. And certainly we saw that with the docetaxel only arm, but with the combination arm, we saw much fewer patients that were progressing as the best response. And then recently we looked at the survival data. I can't really show that now. We're going to be presenting at ASCO. So the patients that received the OGX-011 and chemotherapy lived 27.5 months on average, and those that just received docetaxel 16.9 months or 17 months, which is very similar to what we would expect with docetaxel alone. So very intriguing. It is a phase 2 trial, and phase 3 trials are now planned with OGX-011 plus docetaxel versus docetaxel. So the take-home messages are we don't have a lot for standard therapy. We have second-line hormones, zoledronic acid, docetaxel, and that's about it. You should consider prognostic factors and earlier intervention in those patients that have negative prognostic factors. Hormone-refractory is no longer called that. We now call it castration-resistant because of what we've seen preclinically, clinically, and as well responses to these second-line hormone therapies. And there's lots of promising rationally designed targeted therapies in clinical trials for almost every disease state that are going on in Vancouver. So thanks for your attention, and I'll take any questions.